You are listening to the
World Extreme.
World Extreme Medicine.
The World Extreme Medicine
Podcast.
In this episode, we're going to be speaking about the innovation of virtual emergency centres with Mardi Steere. So what I want to do is really examine the recent innovation of virtual emergency centres in rural Australia with Executive General Manager of Medical and Retrieval Services, Dr. Mardi Steere. So the recent innovation of these VECs, or the virtual emergency centres in rural Australia, it's been spearheaded by Mardi, and it's really revolutionised healthcare delivery in rural Australia. So what they do is harness the technology to provide remote emergency medical services, overcoming geographical barriers and ensuring timely access to care in underserved areas. So with a focus on continuity of care, the VECs integrate healthcare and indeed telehealthcare, remote diagnostics and therapeutics to empower trained laypersons to administer hospital-grade treatment under medical guidance. So this pioneering model not only improves patient outcomes, but also serves as a scalable solution to address the unique challenges of rural healthcare. So to discuss this recent innovation is Mardi. Mardi's with us from Australia today. Welcome to the podcast.
Thank you so much for having me.
It's great to have you with us. Mardi, before we kick off with the questions, could I just get you to speak to a little bit of your bio for listeners, just to unpack your background?
Yeah, I'm an Australian who's kind of lived all over. I fell in love with an American and I did grad training in the US, in Florida. I've worked as a specialist pediatric emergency doctor in Australia. And then my family and I actually moved to Kenya for 8 years from 2011 to 2019, where we did humanitarian work in a tertiary hospital just outside of Nairobi, and then have come back to Australia, and I've been working for the Royal Flying Doctor Service for almost exactly 5 years now. So we do like to get around as a family, but gosh, it opens your eyes to healthcare around the world.
Yeah, absolutely. And like you said, very different in sub-Saharan Africa and various different places, but there's probably some overlap actually, as in some of the rural and remote reach back that we'll explore within this episode. And I guess my first question, Mardi, would be really if you could just maybe unpack the recent opening of the VEC, the virtual emergency centres, and what were the sort of origins of this innovation?
Well, it's interesting. As you said, when you live in a low resource setting, it shows you just how similar we are across the globe. Remote and rural medicine in general has its challenges everywhere in the world. And so there's people innovating in all kinds of different ways, and we have so much to learn from each other. And so it was actually seeing telehealth kiosks starting to emerge across Africa and Asia that were a little bit of the inspiration for our virtual emergency centre. But of course, innovation isn't just about picking an innovation up and plopping it somewhere else. The Royal Flying Doctor Service already had a great foundation in remote and rural Australia, where we have what we call medical chests, which is we train lay people to have hospital grade medications in their home in a locked cabinet, with some training about how to give medications either orally or up the nose or intramuscularly. And so we had some of that out and about. We also had some remote clinics where we would fly in and out to deliver healthcare. And I realized that we had some really strong things that if we brought them together into a single system, maybe we could have a virtual emergency centre combining all of these things.
Which absolutely makes sense, actually, Mardi. And actually, like you said, the enablement of technology at this time really starts to it's serve as an enabler, really. And so maybe could you speak to what advancements have occurred in this space, and really maybe just unpack how the VEC operates, sort of what purpose it serves and how it functions?
Yeah, what we've done with our virtual emergency clinic is we've put it in a really small outback town called William Creek, which has a population of only around 17 people permanently. So it's never going to be big enough to have a permanent healthcare practitioner, whether that be a paramedic, a remote nurse. You just can't sustain a healthcare practitioner full time in a town of 17 people. But at the same time, William Creek's got around 26,000 tourists coming through it a year, and a publican who supports them with a fantastic pub where you can get a great meal and a good drink as well. But he can't be all things to all people, obviously. So the virtual emergency centre is, first of all, a telehealth kiosk. It's a building that has a doorbell that is linked to our operations hub, which is hundreds of kilometres away. And the operations hub will see someone at the front door on their CCTV camera, and the doorbell will ring, and we will buzz the patient into our little telehealth kiosk, which is just the size of, a very small room, 1.5 meters by a couple of meters. But inside that, we've got a telehealth unit. To have a telehealth unit, you need electricity. So we've got an uninterruptible power supply. You also need reliable internet access, and that's where the innovations of the last few years have been so helpful. The low Earth orbit satellite networks developing initially Starlink and then Kuiper on the horizon are really outstanding ways of getting internet access into communities that are too small to have a 4G network or reliable Wi-Fi. So we have set up our telehealth hub so that when a patient goes into a room, they sit down at it. Our operations control centre calls our doctor who's on call. They dial into a Zoom room and just appear on the telehealth unit in front of the patient. And then with that telehealth unit, we've of course got some diagnostic devices, finger oxygen saturation probes, a little heart rhythm monitor, blood pressure cuff, a nice small pencil camera that we can look into someone's throat or into their pupils. And it's amazing how much information you can get from that. So that's the very first small part of the hub. And then, of course, if someone's really sick, we've got an AED there, so we can commence CPR. We will buzz the patient into an adjacent treatment room, which has a bed, has an oxygen concentrator. We can commence CPR virtually through advice, and then we activate that layperson with their medical chest who's going to have morphine or GTN for a heart attack or a whole bunch of drugs on board, and we can actually start treatment with no medical staff in there whatsoever.
Which is absolutely fantastic, actually. And maybe could you walk us through the diagnostic or indeed the just how the medications are being prescribed? Maybe just some of the systematic and governance aspects of how you sort of deliver sort of hospital grade or indeed prescription only medications virtually. How does that mechanism work?
Honestly, I think as an almost 100-year-old organisation, we're very lucky that a lot of this was implemented before today's clinical governance standards even existed. We have adapted, of course, this system to maintain a really strong and build on a really strong clinical governance foundation. And so we have very, very strict criteria around this. We are strongly partnered with state and national pharmaceutical organisations and regulators. We have very strict inventory control, which has been analogue in the past, but is increasingly becoming digitised. We have a very strong audit system of our medical chest custodians. If a single vial of anything goes missing, that does become a police case. And remote and rural populations are not silly. No one wants to take this lightly. Having these drugs at hand is absolutely life-saving. And so many of our remote patients have benefited from these, that the audit, inventory and training processes are extremely strong and have been validated over the years. And we've actually published in medical journals how well this system works. I think it would be really difficult for an organisation to try to replicate this. But it's, I think, a really amazing and potentially scalable model that we're showing that it can be done really safely without risk to patients, risk of missed medications and poor medication management.
Absolutely. So let's look at the scalability of the model, actually, Mardi, because I think it, like you said, it is potentially scalable with a framework of governance behind it. Could you maybe speak to any plans you have for scalability and indeed how you maybe what the mental model is for scaling this maybe throughout rural Australia?
It's interesting when you come up with a plan like this, it sounds like a really good idea, and then you invest $1 million in a remote clinic and you hope like crazy that you haven't been a fool. But as an organisation, we've been really keen to give this a try. And we're actually in the auditing process right now of collecting our data over the first 6 months. Any investment like this, you really want to know what is your return on investment and how do you measure this in a very small population? You're never going to get high volumes or economies of scale. And so the return on investment has to be measured in a few different ways. One is, does this kind of safety net give you a social return on investment in terms of people feeling safer living remotely? Does it help people continue to be retained in their remote and rural communities, knowing that a service like that exists? And then, of course, we're trying to measure some of the cost savings and cost impacts in terms of morbidity and mortality. So what we found in our first few months is there's a combination of financial return on investment. One is in retrieval avoidance. We have had a case of someone that showed up and it wasn't clear if they were having a stroke or not. But with our diagnostic capability, we were able to tell that it wasn't a stroke. It was actually a Bell's palsy. Give them medications there and then, send them on their way, and then avoid those thousands of dollars that it would have taken to fly them to somewhere where there was a CT or a doctor who could examine them in person. Conversely, there's also the patient that arrives clinical. We've had a patient show up with significant dehydration and early kidney injury that we were able to monitor overnight when we couldn't even task our retrieval team because of fog. But being able to monitor their vital signs, give them oral rehydration, continue to closely keep an eye on their blood pressure and heart rate, and give them antiemetics, we certainly improved their clinical condition to the point where they were closely taken care of all night. And whilst they were still retrieved, we do believe that we avoided a more significant kidney injury or ICU stay. So again, those are cost savings in terms of ICU beds, but also in terms of the outcome of the patient, their return to work quicker. Trying to put this together into a financial model that shows that scalability is going to be a challenge, but we're really seeing the results that we were hoping for. And what we would plan to do is roll out similar clinics to similar really small populations that do not have a community paramedic or remote nursing presence.
Yeah, that's fantastic. And like you said, it's how you measure and looking at a spectrum of measurements of both soft and hard measurements around the advantages to these clinics. Mardi, could you speak to, there is analog environments, and we spoke offline about, Nairobi and indeed sub-Saharan Africa being an analog with the tyranny of distance, but Canada is very much a developed healthcare system, has also got the tyranny of distance. But could you speak to some of the unique challenges that Australia faces, which maybe aren't seen in other analog environments?
Australia is such a curious country, isn't it? So much of our population, around 97% of our population, really exists around the coast. And so not only is the centre of Australia arid, because there's no people there is a lack of internet connectivity, which is actually probably one of our greatest challenges. When you look at sub-Saharan Africa, so much of their connectivity and their advances in mobile money and things are because they leapfrogged hard internet connections and went straight to 4G. So the continent of Africa actually has so many fewer blind spots of data connectivity than remote Australia does. And so I think that's one of our really big ones, is that there are just gaps in connection. And that's where Starlink and others are really starting to come to the fore. And it's interesting watching the maps that are developing of that low Earth orbit satellite network and what Amazon and others are looking to do in that. But in addition to that, a lot of solutions developed in places like Canada and Europe are really geared towards the austerity of the winter environment, but a very mild summer. We deal here with the absolute opposite extreme. It's severe heat and often humidity at the same time. And we find that not only not having connectivity, but having to deal with, not being able to uplift drones and other things like that is really a challenge that we uniquely have to solve these problems. And if I think we can solve them here, we can solve them anywhere.
Yeah, indeed. So Mardi, looking at just sticking with the unique environment of Australia, really, could you maybe speak to some of the challenges you face around sort of medical infrastructure? So I guess in a way, just the continuity of medical devices such as computers and indeed, like you said, modems and other things in such extreme environments, but also how you procure and the logistical chain of getting medications into, or indeed just how you both focus on and I guess interface within pharmacies and get this supply chain of medications into these remote areas.
It's a real challenge, and we're certainly not the only ones dealing with this at RFDS. So many of our remote Aboriginal controlled health organisations and state health led remote area clinics have these same challenges. It will often take patients who have had blood samples done, for example, days to weeks to even get their samples into a pathology testing centre, or if they need a refill on a medication, to get that with decent cold chain to a local pharmacy or out to that remote area clinic. And we find we're very reliant on road networks. Which can have their own challenges in Australia's vast outback, or we're reliant on fixed wing aircraft. And in this day and age, fixed wing aircraft are fantastic. They get us where they need to go, but there's such a reliance on fossil fuels that we're absolutely aware of. And there's really an appetite around the world, and certainly in Australia, to leave less of an environmental footprint with what we're doing. So this is why we're starting to have a look at, alternate ways of delivering pharmaceuticals, of delivering blood products, of sending pathology samples. This is not new. We're not pioneering in this area. There's certainly drone networks starting to be developed around the world. But we are starting to watch what's going on around us and think, how can we embrace drones? How can we embrace emerging eVTOL and other things like that? Because our environment really is so austere and so challenged with fuel sources that we need to think differently.
Absolutely. And you speak to, like you say, different ways of delivering healthcare around drones and different unmanned technology. Could you maybe speak to some of the environmental conditions? Because speaking to some of your colleagues, the constant challenge really lies around just the extreme environmental conditions for flight, and indeed sometimes the inability to reach these remote areas by fixed wing plane. How is that part of the plan for future, to maybe look at drone technology when fixed wing airframes can't actually land into some of these areas?
Absolutely. There's a couple of challenges. Fixed wing and helicopters can certainly go a really long way, but for fixed wing, you need a runway, and you need that runway to be accessible both day and night, and you also need it to be accessible during rain. And flooding and night strips can be a real issue if you don't have if you don't have a lot of airstrips as redundancy. And in outback Australia, we don't always have that redundancy. It can be hours drive between airstrips. Similarly, helicopter is great, but they've only got a certain range and you can't refuel everywhere. And so even with helicopter, we do find that there is an outer extreme of range that sometimes we just cannot get to people until the next day, or until a road transport can get them to the outer edge of where that helicopter can go. So rotary and fixed wing are not a panacea. eVTOL is a really interesting area for a couple of reasons. One, that if we can just land anywhere in the desert and take off vertically, it really gets us to the side of the patient a lot more easily. There are going to be ongoing challenges there with fuels. There's a lot going on in the hydrogen fuel space, but then where do you have hydrogen refuel facilities? We're looking with partners around the country about how we can make sure that this is thought of strategically, not just for commercial, but for healthcare and for public and private, all working together. And we have a partnership with the Northern Australia Centre for Autonomous Systems, NACIS, which is a partner of Charles Darwin University, that's working with health to figure out how we can make better progress in autonomous systems. The other thing with drones that's interesting is you can take a drone anywhere as long as you can see it. Going beyond line of sight does require constant internet connectivity. The National Aviation Regulator, CASA, does not want a drone out of someone's connection at any time. And so working with CASA and with NACIS to see how can we get drones to go the hundreds of kilometres that we need rather than just, 10 Ks, is really a challenge that's being worked on by a lot of different smart people at the moment.
Yeah, indeed. And to your point around looking at what the services are actually delivering at the moment, could you maybe speak to, have you had a look at other systems in Rwanda, India, or indeed Europe, as to how they deliver routine medications, vaccines, blood samples? Has there been sort of almost analog services which you've been examining and sort of trying to get some of the lessons learned from?
100%. there's no reason to reinvent the wheel. And what's been really interesting is I think COVID cracked open the door to, sudden demand exceeding supply in some really hard to reach areas, especially for that COVID vaccine. So India's been really interesting to watch. They've partnered with World Economic Forum for the Medicine from the Sky project in 2021. And that's really focused on that last mile of care where roads end and you can't get to populations. And with 1.4 billion people, there's a lot of people that aren't always within reach, and so they've got almost 200 drone services and 5,000 drone pilots in India, and they were one of the first countries to really use drones to cover COVID vaccines. Ghana's been really interesting to watch. They've been working with a company called Zipline, and they delivered over 2 million COVID vaccine doses during the COVID pandemic. And then in Rwanda, there's been a lot more work done on delivering blood supplies, in fact, and they found real effectiveness in developing blood to remote areas in Rwanda. And I've got a colleague who is in Eswatini, in South Africa, who has also launched a drone project delivering healthcare products and blood. And so we're learning everything that we can from them. What we have found as we've tried to adapt some drone systems in Northern Australia is that they just don't perform as well in our heat and humidity. So there's a lot of different providers that we're working with to try to validate, especially cold chain, because keeping all of these things at a reasonable temperature is really essential for most healthcare deliveries.
Mardi, could you speak to just the use and indeed deployment of AEDs within the system for VEC? Is this something at the moment which is the static site AED for the immediate or emergency medical care, or do you foresee that being delivered by drone? How does it work at the moment, and how do you see it working in the future around AEDs and defibrillators?
Yeah, in Australia right now, we've really focused on having AEDs in places that you can get to. And we certainly got AEDs, not just in our virtual emergency clinic, but we've placed them in remote pubs. And there's a really wonderful network of AEDs across Australia. And people are really good at starting to map those so that you can access them at any time. I think drone delivery of AEDs is a really exciting area. In Europe, they've actually been pioneering this really well. And in Sweden in particular, they validated this, the first life saved that I know about in around 2021, when there was a 71-year-old man who collapsed in his driveway. A bystander called emergency services. Emergency services deployed a drone to the bystander who used it and saved a life. And if you look at the literature, Sweden's actually got many more cases now of lives saved in that area. What's really interesting is what is the cost benefit? People want to know how much it's going to cost to do these kinds of things. When it comes to COVID vaccines and blood deliveries, that's actually a really easy economic equation, because the higher volume you have, the more cost effective it is. Emergency services are a little harder because you might have a drone sitting around for days that's not needed and you're paying a drone pilot full time. So figuring out cost effective models of drone-based emergency care is emerging, but there is a lot of work going on, especially in the Northern Hemisphere, around emergency response drones, not just for AED delivery, but in search and rescue. There's been a lot done in Canada where this is used pretty routinely now, especially in the cold and in the wilderness. So how we apply that to Australia, if we could get a copy of the financials, that'd be really nice to see. We're really excited about the possibility of integrating primary and community health and emergency drones for really cost-effective solutions.
So it's fantastic, really, and everything I've really got from you over this past half an hour, and just doing some research, is that Australia really is leading, and Royal Flying Doctors are really leading the way in this innovation. Could you maybe speak to some of the, because like you said, there is a unique population which is largely centered around the outskirts of Australia. Could you maybe speak to some of the opportunities that exist for the country to continue to lead in the development and implementation of emerging healthcare solutions?
Yeah, in addition to the stuff that I've mentioned, I think that we live in a really interesting time right now where there's an acceptance and an embracing of remote wearables that has never existed. And so I think be hard pressed to find a community in Australia where someone's not wearing a Fitbit or an Oura Ring or one of these other commercial devices. And I think historically in healthcare, we've tended to try to invent things and push them upon people. And I think that thinking about things in a different way and saying, what are people using and embracing, and how do we sub into the behaviors that already exist and use them for better healthcare is really where we're at. And so, whilst we can mostly determine heart rates and sleep patterns and oxygen saturations now are actually really common in some of these peripherals, how can we add on to that to see if we can listen to breath sounds with, home based stethoscopes? Most people over the age of 60, I reckon, have probably got their own blood pressure machine if they've ever had a high blood pressure. And so the remote diagnostics that just exist already in your average home are increasing on a day-to-day basis. I think one of the things that I'd like to see next on the market is a 12-lead ECG, and I honestly don't think we're probably that far off. People want to know if they're having a heart attack. So rather than creating something and trying to roll it out, I'm really interested to see what the commercial market comes up with, and then that the TGA reluctantly approves. But in addition to the kind of home-based stuff, I think there's a lot more that we can do with supporting remote staff with diagnostics. I think a great example is ultrasound. And I don't know, I remember reading a news article years ago that Tom Cruise had an ultrasound in his own home, and I thought that was the dumbest thing I'd ever heard. But I do think that equipping remote paramedics and nurses with ultrasound, and then even if they have not been trained or skilled in how to use them, with telehealth, we should be able to guide people on where to put the probe and how to interpret the images that are sent digitally. I think that there's a lot that we can do diagnostically with remote ultrasound and remote imaging that's really going to explode in the next few years. And I'd love to see healthcare at the forefront of embracing this and validating and trialing these things safely whilst rolling them out to populations that really have very little.
So finally, Mardi, just as we're coming to land on the conversation, could you maybe speak to what's next for the Royal Flying Doctor Service? What is some of the next innovation within or indeed consolidation? Is it an audit of the service, or indeed is there an extension of the innovation at the moment? What's next in this space for yourselves?
One of our core values as an organisation is collaboration. And so, what I would say is that RFDS certainly doesn't stand alone with this. I didn't mention with the Virtual Emergency Centre, but we had tremendous support in a grant that we got from the Outback Communities Authorities, the local population that really wanted this. Every time we try something new, we're partnering with a university or partnering with a grant organisation or our amazing donors and our local and state health departments. And so, partnership with people who are passionate in adjacent spaces is really where we're at. And the aviation industry, eVTOL entrepreneurs and companies, virtual reality providers, drone providers, we are all about finding what innovation is happening and then coming together and saying, can we help with our systems expertise and with our history in bringing things together to help pull different people together into a team that are learning to think in new ways about how to provide health. And so that's what we're all about, is whoever is out there leading, let's be a part of a conversation, and we're always stronger together than we are individually.
That's fantastic. And I think what we'll do in the show notes is we'll put a link to the virtual emergency centres just so that listeners and indeed viewers can see the fantastic innovation and indeed what the fundamental components of that innovation. So we'll put that in the show notes. But just leaves me to say thank you for the last half an hour, Mardi. It's been hugely insightful just to get your perspectives on this innovation. So thank you.
Thank you so much for having me. Absolute joy.
Thanks for listening to the episode. Please feel free to rate, review and subscribe on whichever platform you're listening to. Please also head over to the World Extreme Medicine website where you can find more engaging content on extreme medicine webinars and indeed the collection of courses from our global network, including humanitarian, disaster relief, expedition, space, military, tactical and performance medicine. Thanks again.